Log on, tune in, find out. Another good idea from Cambridge.
It's my pleasure to introduce the first speaker, Anthony Atkinson. But before I do that, before I let you speak, let me just say to all three speakers, please give at least 5 minutes for discussion. Okay? So, Anthony, you start this session on clinical trials, and the title, as we see, Randomization, Regularization, and Covariate Balance in response adaptive designs for clinical trials. Please.
Okay. I'll just turn this off. I think it. Can you hear? I suppose this is on. The microphone's on, is it? I will just turn this off. Yes, I will just turn this off. I think it improves. So, thank you very much. Yeah, I'm not. Despite our long, if infrequent, collaboration, I'm not Valery Fedorov. He has had, unfortunately, to go back to the United States to deal with the drug industry there. Okay. Now then, that's interesting, isn't it? Yes. Okay, that's fine. Sorry, that's the LS. Oh, this is joint work with Artinu Biswas. You've seen that. I'm going to talk about some work on phase 3 clinical trials. Particularly, I'm interested in sequential clinical trials. Patients arrive sequentially. Each is immediately given one of T treatments. The patients have a vector of prognostic factors, could be anything like gender, previous medical history, weight, and so on. The main purpose is going to be to find the best treatment. Subsidiary purpose is to estimate the treatment effect, and responses on patients. I'm going to assume that responses on patients before the one that you want to allocate are already available. Sometimes this would not be the case, but often surrogate responses based on biomarkers or something are available. So we will assume that you all have complete information on previous responses. And part of the problem is that you may stop for at any point. So you don't want wherever you stop, you don't want the trial to be too unbalanced. So here are some requirements. We want adaptation. We want eventually to treat more frequently with the best or better treatment. We want some kind of balance across prognostic factors, so that all kinds of patients should get all treatments. We would like a balance insofar as that is possible wherever we decide to stop, and we need some randomization. Those of you, many of you I'm sure will know about the Lanarkshire milk experiment. And we also need the experiments to be blinded. What I'm going to do is I'm going to use adaptations, I suppose, of the sequential construction of optimum experimental designs to do this. And I will actually spend quite a lot of the time available talking about how you might assess any proposed design. What are the properties that a good design should have? Okay. So here is just a linear model. The Z's are the linear model that you generate might be a second order response surface from the prognostic factors. We will assume that you analyze the data using least squares. You may need to transform the response. If the effects are small and you're using a generalized linear model, then this theory will also apply. Here is an optimum experimental design. I will be talking about variations on d-optimality. The d-optim design for the parameters in all the model maximizes this determinant of the information matrix. When patient n plus 1 arrives, the allocation of the first n patients will already be known. So if treatment J is allocated to patient n plus 1, we know all the rows of the design matrix. We now have a design matrix with n plus 1 rows, and the n plus first row will be Gj n plus 1, depending on which treatment we use. So if you are sequentially constructing the d-optim design, you would choose that J, that treatment, for which that variance there, this derivative function, was a maximum. We're not actually interested in all the parameters. Suppose the interest is just in S linear combinations of the parameters, then I'm sorry, instead of D optimality, we would use DA optimality, which would maximize that determinant there. Similar kind of thing. You can sequentially, this is getting worse, isn't it? It may get better. I'm sorry, it's a nuisance for you, it's also a nuisance for many of you, because it also seems to be making your throats feel a little bit sort of hysterical thing in a way. Okay, let's get back to let's get back to this kind of medicine. Let's see how we go. Okay. Very good. So here is why we're interested in linear combinations of the parameters. These are the treatment parameters that we're interested in. These are the nuisance parameters that go with the prognostic factors. So these will just be nuisance parameters. If we look at a linear combination of the parameters, there are two treatments, we'd be interested in perhaps this difference here. Zeros then in our linear combination for all the nuisance parameters. And here, if we want some unequal allocation, we want to allocate proportion of P of patients to treatment 1 and a proportion 1 minus P to treatment 2, then you want to minimize the variance of the estimated parameters for this linear combination. So the treatment mean in this case, and when the P is equal to half, we'll be looking at just the difference between the two estimated treatment effects, and there will be Q nuisance parameters, theta, and these parameters here. You can do the same thing with 3 parameters. And I'm going to create adaptive designs by using the data to choose this skewing proportion here, P. Often, P will be a half. Not in my examples, but often in clinical trials, people are desiring to compare 2 treatments at equally. But quite a lot of clinical trials in the literature have skewed allocations, a bit more than on optimum designs. The design region is the choice of treatment for the next patient, and we could sequentially allocate treatments to give DA optimum designs, minimizing the variance of this linear combination of the parameters. And I've already said what the sequential design construction will be for D optimum designs, but we need to introduce randomness. I will discuss a variety of rules for doing that in a moment, but just first I would like to talk about how do we measure the properties of these designs, which are optimum in the sense that they're trying to reduce the variance of the parameter estimates, but we also want a little bit of randomness in the allocation. This, those of you who were here for some of the previous conferences, there were some random allocations in clinical trials came up, but we didn't have much discussion as to ways in which one might measure this, or even, what the effects could be. So, the important point is that the effect, if we're running along, we won't just, if there are 2 treatments, you'll just give one and then the other one and then the other and so on. Well, it's easy to guess what is going on. The idea of the randomness is to make it less easy to guess what is going on. And in that way, the effect of randomization will slightly unbalance the trial. So even if n is even, you won't necessarily have exactly half of the patients getting one treatment and exactly half getting the other. Is that okay? I mean, this is really the basic thing. That's not what I meant to do. So this then is an important slide, I think. If there are no covariates, the optimum design assigns treatment 1 to a proportion P of the patients in the skewed case, and the variance of the estimated linear combination is just sigma squared over n. And for other designs, here is our information matrix, and we have this form here. then the efficiency of a design is this quantity here, which depends on the information matrix and on the vector of coefficients of the parameters. As the number of patients gets larger, and we continue to allocate using some randomized version of sequential design construction, the efficiency will go asymptotically for large n. It will go to 1. However, it's interesting to look at the loss, which is defined by writing the variance as in this form here. So here is the variance. It's sigma squared. Here for the optimum design, it's sigma squared over n. If it's going to be a little bit larger, then we can write it as sigma squared over n minus this quantity here. If the loss is small, if the design is highly efficient, this loss will be small. If the design is inefficient, then this loss will be large. And as we shall see, this loss settles down to specific values. Look at this. This is the number of patients. And the loss, I think this comes up again on the next slide, the loss can be thought of as the number of patients on whom information is lost due to the randomization. The other thing is bias, selection bias, which arises because the clinician can guess which treatment is to be applied next and allocate accordingly. We want to avoid that. So we just define bias as the expected number of correct guesses minus the number of incorrect guesses. This is for 2 treatments. 1 for perfect guessing is bad, 0 is good. And you can estimate, in complicated cases, you can estimate this by simulation. And in calculating the bias, I will always assume that the clinician is making the most intelligent guess that could be made given all the information on the sufficient statistics or previous information. So here then are some of the designs of the kind of thing that I'm going to talk about. The first thing is a rule D for deterministic. This is sequential design construction. You allocate that treatment for which the variance is a maximum. Okay, so you're doing the best you can to reduce the variance of the linear combination of the parameters that you're interested in. Randomized, we know our target proportions Pj. We allocate the treatment J just with this probability. So these are the 2, you could probably think of other designs. These are the 2 extreme reasonable designs. This is the one which is random. This is the one which is deterministic. Here is a rule that comes in between, in which we include this variance of the prediction coming from design theory. If this is large, the treatment is underrepresented in some way, and you'd allocate more to that treatment. And one can also use something based on Efron's biased coin, 2/3 for the one with a probability of 2/3 and 1/3 here for these PJs. Okay. There are some results on the values of loss. As I say, it's the number of patients on whom information is lost due to the lack of balanced optimality of the design. With a random element in the treatment allocation, then it's going to be a random variable. Its expected value, I'll call it this. Then there are some asymptotic results. For random designs, Q, you probably don't remember, is the number of nuisance parameters, and the expected value of the loss is Q. For this rule A given above, it was shown to be Q over 5. For the deterministic, the design becomes completely balanced as you run along, and the loss is 0. And it is easier to guess the next allocation for rules with low values of loss. So the random allocation, it's hard to guess here. The deterministic, given all the information, because it's an optimum design, you know exactly what is going to happen next. So here are some simulations of loss and bias. Here we have loss. There are 5 nuisance parameters. Here are the number of patients running up to 800. Those pictures look very much the same, so you need to look at the letters in the right-hand side. So this is This is the loss for random allocation, indeed equal to 5. Here is the bias for random allocation. You can't guess what the next treatment is going to be. These results are for the probability of allocation being a half. You can't guess. So here is the rule based on dA optimality. The loss comes down to 1 q over 5. Here is the bias that decreases steadily here. And here is the Efron type rule coming down here for loss, up here for bias. And the point is that large loss, that's rules with a lot of randomness, and small bias go together. I have done it elsewhere, but I won't do it here. You can actually plot these two and see which rules have good combinations of loss and bias. Some of the traditional rules, the traditional minimization rules, due to Simon and Pocock, for example, if you plot them on this loss and bias plot, they're not admissible. Okay. How are we going to generate rules? I just put up some rules. Well, one way which one can find a rule that one would expect to have good properties for these biased coin allocations is due to Ball, Smith and Verdner. They weren't at all concerned with, I should make it clear, they weren't at all concerned with clinical trials. They were concerned with design of experiments in general. But the idea is they wrote it down a utility that combined both the variance of the parameter estimates and randomness, and they were these two quantities here. And here there is a parameter gamma which provides a balance between randomness and parameter estimation. If you do a little bit of algebra on that, you get an allocation rule of this form. So these designs, you see, here we are. Here are the target probabilities. Here are the variances coming from optimum experimental design. Here is the parameter gamma. What happens as you get more and more trials? Well, this is unnormalized. I haven't divided by n. It's not the kind of thing you use in the equivalence theorem that has a value p when you get the optimum design. It has the value p over n because it's not normalized. So this is going to go down. This is going to get smaller and smaller. And as the number of trials then gets larger, this will move towards random allocation. But for small values of n, the trying to achieve balance in the design is very important. That's what this is saying here. It's near the deterministic rule for small n and tends to rule r as n increases. So you've seen some of these pictures before. Here is loss for the classical rules. Here is loss for these Bayesian rules. And you can see initially they force balance. And then as the number of patients increases, they become increasingly like the randomized design. Just notice that when we get to adaptive designs, we will see that the losses are much higher. All right. How do we do all this for adaptive designs? What we've done is we use pre-assigned target probabilities, P1 for the treatment that comes out to be best, P2 for the next, and so on. And we actually just take ranks of these things. So the treatment that is ranked best will be allocated with the target probability of P10 and so forth. In running trials, sometimes due to the randomization, you can get very extreme results, and we introduced a regularization so that all treatments were assigned to at least root n of the treatments. Have I got that the right way around? Anyway, here is an example with 3 treatments and adaptive designs. Here is the loss. here is the allocation proportion. Here are somewhere, here are the targets 0.8, 0.15 and 0.05, and the losses should eventually come down, I think. Yes, the losses should eventually come down to 5. You can see in this case they are not too big, and the proportions eventually trend up towards the correct values. These little zigzags here are due to the effect of the regularization. They're stopping the design getting too extremely unbalanced. We could also look at individual trials. Here we are. That is the effect of regularization. I hope this is clear. This is the loss for individual trials going from 500 up to 50 to 400 patients, and this is the regularized design. And you can see these, particularly for small numbers of patients, small n, these are much more scattered than these. So the regularization is making sure that the designs are not too extreme, because high losses come from very highly unbalanced designs. A little bit about inference, and then perhaps we're getting towards time to stop. Is that right? You remember, I said something about the form of the rule, this Bayesian rule. We had something that was 1 plus, well, there was a target probability, 1 plus a variance term that was going down to 0. So eventually, these rules are becoming more and more like random allocation. So all treatments have a positive probability of being allocated, so that asymptotically the designs have an information matrix, which is just that for least squares, and it's just possible. So there's a lot of concern in adaptive designs about whether they converge to the targets you want, but in this case, because you cover all the treatments, you get what you want. Here is just an example of how good this asymptotic argument is for small samples. These are t statistics for testing equality of treatments, when in fact they're not equal. So you have to adjust the t statistic, but I'm trying to show the properties of adaptive designs. Here are box plots of the t statistics, and here is a QQ plot of the t statistic for n is equal to 50. So even for small samples, the standard least squares analysis seems to provide good inferences. Well, I think there are more things that, of course, as with any speaker, there are many more things that I could say, but this is what I've talked about. Oh, I haven't talked about power, but since my wife is the chairman, I think I had better obey her and stop now. Thank you very much indeed.
Well, so some good things come out of it. Well, the floor is open to questions and comments, please.
Your criterion for bias had to do with the chance that the doctor could guess the next treatment.
Right.
But
yes.
that doesn't necessarily correspond to bias in the estimate of the treatment effect. In fact, if you had blinded assessment of the outcomes of the patient, you wouldn't worry about your bias criterion at all. You focus much more on the loss issue and efficiency.
Yeah. I do know a very famous statistician at a large and prestigious, I suppose one would put it, American university, who managed to get himself randomized onto his preferred branch of a trial on prostate cancer. I agree that in principle blindedness could do it all, but and multi-center also helps. I think it's useful to be extremely pessimistic and to try to do this. But yes, I quite agree with you. Yeah.
I mean, if the doctors can't put their best patients on one trial, you've got bias.
Yes, I suppose that would be true if they can guess and assign the treatments
Yes.
differentially. But in the studies I've worked on, it's been more an issue of whether they can guess the treatment as it's already been randomized. So there's a
What I've
difference
seen
between
is
blinding and masking for the
Yes, okay.
randomization process.
Yeah, okay, thank you. Yes.
Yeah.
That's it.
Well, I was just going to say, what I've seen is they know the next treatment's coming up, then they hold back their patient or push their patient
Right.
forward to make sure that they get
Oh,
what they
okay.
want.
Then it would be a concern, yes.
Any further questions, please?
Model of clarity, it must have been good.
When do you stop? When do you stop these trials?
Well, the idea is that we're concerned, because we're looking at all possible values of n, we're trying to really be reasonably balanced whenever it is stopped. I don't have any formal kind of stopping rule of the sort that Chris Jennison was talking about a couple of weeks ago. And I suppose another thing that I'd actually quite like some advice on is that once you've actually started to set up a clinical trial, you've got the whole mechanism in process, you might perhaps want to let the trial run for several hundred or however many patients you think you want, rather than continually deciding whether to stop or not. Okay. Thank you very much. Yeah.
Well, thank you very much again.